Good morning and welcome to Trio Maryland's third virtual transplant conference. We are so excited that you are joining us today for this educational event. I am Marty Marin, president and co-founder of the Maryland chapter of TRIO, which stands for Transplant Recipients International Organization. I am a liver recipient November 2009 at Johns Hopkins Hospital, and I'm closing in on 15 years or 5,296 days. Yay. After my transplant, I became a volunteer at Johns Hopkins Hospital and at Infinite Legacy, and then started working on establishing a Maryland chapter of TRIO. Our mission is to connect transplant recipients with one another, to provide education on transplant topics, and by offering non-clinical support, we complement the services of our healthcare professionals. During the last 11 years, we have offered over 120 monthly educational meetings. We have hosted 5 in-person conferences and 3 virtual conferences. Transplantation is a journey, and our conference brings you topics and information to help you navigate the next stage of your life. TRIO Maryland is a nonprofit 501c3 organization founded and managed by transplant recipients. We are self-funded, raising money we need to continue our programs. We can offer great events due to the generosity of our members and families. With your financial support, TRIO Maryland will continue to furnish timely and educational information to the transplant community. Let's take a few minutes for some thank yous. I would like to thank the TRIO Maryland Board of Directors and Ashton Conference Planning Professionals, our web hosting company, and TRIO for all that they did to manage the event. Thank you to our partners, Infinite Legacy, Johns Hopkins Hospital, and the University of Maryland Medical Center. I would also like to thank all the presenters for their time and for sharing their expertise on important transplant topics and for sacrificing a Saturday morning. We have wonderful sponsors that are involved in our transplant community. They make our life better, and we wouldn't be here today without their support. Thank you to our sponsors that have supported this year's virtual conference: TRIO National, the National Kidney Foundation of Delaware and Maryland, CareDx, Anatomy Gifts Registry, Peak Relief, and Infinite Legacy. Don't forget to check out our sponsors and their websites for details on their products and services that they offer. Our sponsors make our transplant life better and easier to navigate. Thank you, and we hope today is informative, educational, and helpful as you make your transplant journey.
What a great introduction and a great way to kick off the 2024 event. We couldn't do it without our sponsors, and we encourage all of you to visit their websites to learn more. TRIO Maryland is excited to be bringing you this conference virtually. A quick reminder about your individual schedule. Please remember that all sessions have separate Zoom links. You can access links 15 minutes before the session starts, and the webinar will officially open 5 minutes before the start time. If you need support, please text 703-593-1682. I'll put that number in the chat. The first session today is Thoracic Transplant 101, Heart and Lung. Please post your questions in the Q&A tab, and we will share with the speaker after the presentation as time allows. Our speaker, Gina Pace, is currently the transplant nurse coordinator for the lung transplant team at the Johns Hopkins Hospital. Gina has been with JHH for the last 17 years, and her role includes nurse navigator and pre-lung transplant education. Gina is an active member of the TRIO board and has been since 2019. Welcome, Gina.
Thank you, Hazel. Let me see here. I'm going to share my screen so we can get started. Appreciate the opportunity that Marty and Michelle Marin have offered again this year. It's been a pleasure working for them with TRIO, and this year I'm going to do the preparation for heart and lung transplant solo this year. Deb Carter was my co-person in crime over the last couple of years, and she has since retired, and she's now sorely missed. I'd like to start with the heart transplant journey, and I would like to tell you that the objective of today's Zoom meeting is to make sure that everyone understands, what it is to be considered a heart transplant referral, how we go about doing the transplant evaluation, why we do it the way we do, the timeline, and basically who is all involved in that the transplant process. So there's many indications for why you would need a heart transplant. The number one is the end-stage heart disease that has not been amendable to any more medical or surgical therapies. And all of those must be exhausted before we would entertain thinking about a heart transplant. You have different classifications for end-stage lung disease, and it is classified by the New York Heart Association, and has 4 stages. But when you get to be about class 3 or 4, that's when the appropriate time is to be referred for a heart transplant consideration. You have to have had your symptoms for progressing probably over about a year or so, and your physicians have felt that your survival is less than 50 to 75% with the current therapies that you're on. You have also probably had to have demonstrated some pretty poor performance when they've done metabolic exercise stress testing. Some of the reasons that you have end-stage lung disease could be either a congenital heart disease, it could be an ischemic cardiomyopathy, and this means where the blood flow has been cut from your heart muscle. The supply has gone down from an occlusion, a blockage. You've had heart attacks, and has that heart muscle to not work it as well or not at all. Or it could be a non-ischemic cardiomyopathy that could have taken place where the heart muscle just ceases to function well and gets worse and worse and worse. This could be familial reason, some hereditary factors involved, or it could be what they call idiopathic, which means we really don't know why it happened, but the heart muscle has been affected to the point where it no longer is able to function properly and give your body the blood flow it needs. You could have also had some valvular diseases where, they've tried replacing some valves and the heart muscle continued to fail. Or you could have had some sort of electrical problem, what we call refractory ventricular arrhythmias, where when your electrical system messes up and doesn't work well, it can't send the right signals for the mechanical part of the heart to work. So these would be the indications for heart transplant. Now, there are some potential contraindications for thinking about a heart transplant. Things like if you have an advanced age of over 70. Now, they will look at things case by case, but you must understand that once you are over the age of 70, getting you through the evaluation and the transplant itself can come with a lot of struggles for people that are older than 70. Your rest of your body is aging at the same time. Your kidneys are over 70. Your digestive system is over 70. Your lungs are over 70. Your head is over 70. Everything is affected by that. And we need all those parts to be in good functioning order. And we find that there's an increased risk for complications once you are over that age. If you have an active infection, clearly we could not immunosuppress you for a heart transplant with an ongoing infection. That would have to be completely resolved. If you have a very, very severe pulmonary hypertension picture, this would be something over 60. It makes it very difficult to put a good, strong heart into a body that has this blood pressure, this internal blood pressure, this pulmonary hypertension that makes the blood and the heart pumping the blood out to the body more difficult. And actually, the heart can't do that well if you have that systemic severe pulmonary hypertension involved. Another reason that we would potentially say this is not the right option for you is if you've had an acute pulmonary emboli. That's where there's a blood blockages, there's clots that are actually in the pulmonary vascular system. So you couldn't get the blood to the heart or back out to the lungs and back to the heart again properly. If you're too heavy, if you're morbidly obese, your BMI is over 35, or if you're cachectic, you're under 17 of BMI, you don't have the reserve, you don't have the ability to heal well with either of those factors. If you've been smoking or you're using any sort of substances within the last 6 months, that would have to be completely stopped and surveilled to make sure that you are going to be able to withstand the stress of surgery and not try those things after transplant, because again, they would definitely harm anybody that would be going through a transplant and hurt the organ afterwards. If there's some cancers, now it's a case-by-case basis, and I'll go into that a little bit further down the road, but cancer treatment has become so advanced and better that we used to have a timeline of anyone that's had any cancer other than skin cancers less than 5 years was not considered a transplant candidate. But now, depending on the type of cancer and with the therapies that they have out there now, you could be cured a lot sooner and considered to be safe to take to transplant earlier than 5 years. So that is a huge breakthrough. If there's any major systemic diseases, if you have kidney issues, you have liver issues, these all have to be working well for the medications that we need to give you to work well and to actually be able to make you sustain those new organs. If you don't have the right adequate social support or the financial support, this is going to make it very, very difficult. So we want to make sure that that's all in place before to meet transplant candidacy. Again, if you have any psychological issues, they too have to be sufficiently managed so that we can allow for a safe post-op transplant care. And of course, if you have a history of non-adherence, not meeting keeping your appointments or taking your medications as prescribed, those also would be some contraindications for moving forward with heart transplant. So we get our referrals for transplant in many ways. A patient can actually self-refer, or we actually have the cardiologists refer the patients to us once they have been deemed to be an end-stage heart disease. We also simultaneously do referrals to the LVAD program, because sometimes if you're not a candidate for a heart transplant, you might be a candidate for the ventricular assist device simultaneously. It could be a bridge to transplant, or it could be destination, that you only need to have the VAD. We also will ask the financial office to do a clearance before we start the evaluation. So we make sure that you not only have the benefits to cover the entire testing and consultation process, but also that you would have surgical clearance once we were able to finish all of the testing. So the heart transplant evaluation itself, it's a combination of many, many consultations, lots of diagnostic tests, lab work, health maintenance exams such as a colonoscopy, a mammogram, a pap smear, a prostate serology, and dental clearance. And then, of course, when we put you through all these tests, the CT scans, the echocardiograms, the right and left heart catheterization, carotid Doppler studies, pulmonary function tests, once we put you through all this, depending on the findings of these tests, we'll determine if we need to do additional studies to maybe answer a question that we have, or look at something a little bit more in detail that the initial diagnostic tests demonstrated. So the scheduling of the initial evaluation is in the heart transplant clinic, where you will get heart transplant teaching and LVAD teaching as needed. The evaluation has to be consented first, so the consultation is considered your first test. This signing the consent to be evaluated and start the evaluation testing does not mean you're automatically considered a candidate, but that you are in the evaluation process to determine if you would be a good candidate for a heart transplant when it is the right time. We'll schedule all the necessary testing, and we have, a goal to complete any outpatient evaluations may take up to 4 or 6 weeks because there's a lot of tests to be coordinated and there's a lot of specialists. So it takes a little bit of time to get all through those things. If it's an inpatient evaluation where somebody is already here and they need an urgent evaluation, we usually can get that done within 2 to 3 days. So you get all of the testing done, and then we have to present everything to the heart transplant team. And this is made up of several cardiothoracic surgeons and cardiologists and nurse practitioners and PAs and therapists. And they listen to all of the testing to determine if you would meet candidacy. These are weekly meetings. Once we have all of the committee hear the results, they will deem you whether or not you're a candidate or not. And then we will put you back through the insurance clearance piece to make sure that you have a surgical clearance as well from an insurance perspective. And then we would put you on the heart transplant list. A listing letter would go out to you, letting you know that you have been officially activated on the UNOS transplant wait list. So a little bit about what UNOS means. It's the United Network for Organ Sharing. This is the governing body. It was a National Organ Transplant Act that was initiated in 1984. It's a nonprofit organization, and the membership includes all transplant hospitals, all the organ procurement organizations, and the independent histocompatibility laboratories, general public members, and some volunteer health organizations. This group determines how we list a patient, what the requirements are, and how organ procurement takes place. So as you can see by this map, the United States basically is broken down into different regions to distribute all of the organs in a fair and timely manner. Johns Hopkins happens to be in region 2, but we do go outside that to each region as needed, obviously depending on the sicker the patient is, they'll draw in more offers from other regions as well. So there's different statuses when you get put on the heart transplant list, and it does depend on how critically ill you are. And the statuses go from status 1 down to status 6. So 6 would be the not as sick as someone that's at active status 1. But status 1 would be somebody likely would be in the hospital waiting for the transplant, whereas status 6 may be somebody that is not on quite as much support, medically speaking, and less critical than status 1. And you would be evaluated weekly and monthly while you're on the heart transplant list, and the status may change depending on your condition, your clinical condition. I would tell you again that the organs are allocated to the most critically ill patients first, and they typically go out to about a 500-mile radius. So once you're in the waitlist phase, like I said, there'll be follow-up visits in clinic, and they're at least every 3 months, but they could be even more frequent depending on your level of illness. You would keep the transplant office updated with any changes in your medical condition. If your weight has changed, your phone numbers change, and if maybe you have insurance changes, because you may be waiting on the heart transplant list for a while, and we really do want to make sure we know everything that's going on with you as a listed patient. Because if you get that call, we don't want any surprises down the road. We want to make this as smooth as possible. Now, you may be listed at multiple centers if your insurance allows, And if that's the case, and you are looking at another center as well, we do share all of our test results with those other centers. So maybe you don't have to get everything done twice, but that would be up to the other center as far as what things they would repeat, like consultations and things like that. There are going to be some virtual support group meetings that are offered throughout the year. They are always encouraged, to really listen to what other people are going through. Would be very helpful and help you prepare mentally. And then you will just be waitlisted, and you'll just wait to be prepared to be admitted for the heart transplant when that happens. So every organ is chosen according to maybe the size, the blood type of the candidate. So, this is a cute little cartoon here that it's not really like going to a vending machine. The organs are quite rare, and matching and meeting the candidacy is so important. So let's talk a little bit about the heart transplant surgery itself. Okay, it's considered an orthotropic heart transplant. It's where we match your body size and your blood size and your blood type. It's a sternotomy approach, horizontal incision made down your chest bone. It's the donor heart transplant usually takes about 4 to 6 hours, and they consider it a bi-cable technique. And as you can see by this picture, where they cut the aorta and the pulmonary artery and reconnect. The postoperative course includes about a 2 to 4 day ICU stay. During that time, you're intubated, and they wean you and extubate you as soon as they can so that you can wake up and breathe on your own. The total hospitalization is typically 10 to 14 days. And this depends on a lot of things. Your vital signs have to be stable. You should not have any signs or symptoms of infection or rejection, no bleeding. You're taking all of your medications by mouth. You're able to get up and move, and you've started some sort of nutrition. And then, of course, all the medications that you're going to be taking will be taught to you during that time. And this is a good time to include your care providers that are at home, so they understand what medications you have to take, when to take them, when to call the office if there's been a side effect or an issue. And also, there's going to be a lot of teaching about what you can and can't do when you get home initially to protect that incision and allow for adequate healing. So the heart that you've been given is not connected to your nervous system. Clearly, it's been taken from the donor, disconnected from their nervous system, and then placed in you, but we don't reconnect the nerves. So as a result, the normal process when somebody is going to get up and decide to walk up the steps is their heart senses from the neurologic system that I need to get up and move. I need to pump faster. I got to work harder for this body that wants to walk up those steps. Well, in the denervated heart that you would receive, your resting heart rate would be somewhere about 90 to 110. And the heart rate is dependent on all the circulatory hormones called catecholamines, such as epinephrine and norepinephrine, that typically respond, but they respond slower now because you don't have the nervous system attached to this new heart. So what all that means to you is that it takes you a little bit longer to warm up and cool down from an exercise, or maybe even just a change in position. You just have to take it easy because your heart is going to have like a delayed response. Okay, there's going to be several medications that you will be taking after you have a lung transplant, but the 3 main immunosuppressant medications, we call it the drug regimen. It's like a cocktail that helps lower your immune system safely, are demonstrated here on this slide. The main anti-rejection medication, tacrolimus, is on for life. That is non-negotiable. You will stay on that for life. You will take that every day. You will have it monitored in your blood weekly initially until we get the right dose for your body. We don't want to have too much of the tacrolimus in your body because it would cause kidney problems. On the other hand, if it's not high enough doses in your body, then you're really left unprotected and at risk for rejecting that new heart. Some of the side effects from, the tacrolimus could be that you get a little tremulous, or you get a headache in the front of your head, or that your blood pressure will go up. And of course, we're monitoring this. You're monitoring it at home to make sure that that can be controlled. There are sometimes some medications, some meds, I should say, that do not like grapefruit juice, do not like pomegranate juice, because they will definitely interrupt or enhance the absorption of tacrolimus. So we are going to ask that you refrain from ever having those again. Something else that we absolutely encourage is to avoid marijuana. Again, that could potentiate some of the dose levels of tacrolimus and make it very, very difficult to keep you controlled. Another medication that we use for immunosuppression is Cellcept. Of course, that's not monitored by a blood level, but more of side effects, such as having some GI stress and bloating, diarrhea, nausea, or some neutropenia where your blood counts drop. So they watch that and titrate as needed. And then, of course, the prednisone. That is a steroid. They start out with higher doses and they will wean you down over a couple of months. Some of the side effects of prednisone are increased blood sugars, and also it could slow down wound healing. So we want to make sure that we get that down as quickly as we can safely. Of course, there's more medications that we add to this list, but these are the 3 immunosuppression medicines that must be taken for life to keep you from rejecting that heart. When you go home, you'll have weekly visits in the clinic. You will also have heart biopsies where they bring you in as an outpatient and they go down and take a little piece of tissue from your heart and send it to the lab, look at it under a microscope, and can see at that first cellular level if there's some level of rejection. And just so you understand, the heart that you're getting, it's a match with you, but there are certain antibodies that are never going to be completely matched up. So your body will always identify it as this is a foreign organ and want to try to fight it. So the medications that we just talked about on the prior slide keep your body from trying to fight this new heart. So the biopsies are important. The weekly visits are important because some of the subtle symptoms of rejection could be as simple as a change in your blood pressure, a low-grade temperature of 99, maybe a very subtle fatigue that has come over you. So we help assess that together to make sure that we're on top of it. You'll get a lot of lab work done. Again, I told you because of the medication levels that we need to monitor. We will ask that you go into a cardiac rehab program for at least the first 12 weeks. And that's just to start exercising you and that new heart so that it can give you its maximum ability and you will feel better every single day as you get stronger. We'll continue to watch your medications and adjust them as needed. We'll monitor for those side effects that I talked about and the infection and rejection pieces. And it's so important that you stay really close with your team, your transplant team, so that we can assess and treat as needed to keep you safe and keep that heart working for you. And this is just a nice slide of the team members behind the scenes here at Johns Hopkins. This is of nurse practitioners and some of the navigators and the LVAD staff and the nurse and let's see, some social workers in there. It really does take a village to help somebody move through the evaluation process to listing to getting the transplant and then maintaining your health after a heart transplant. Okay. So moving on, the lung transplant process. This is going to be very similar to the heart transplant with a few differences, which I'll go ahead and outline for you. First of all, the indications for lung transplant are having certain diseases that lead up to an end stage problem: COPD, alpha-1 antitrypsin deficiency, idiopathic pulmonary fibrosis, or an interstitial lung disease of other origin, cystic fibrosis and bronchiectasis, pulmonary hypertension, and sarcoidosis. These are the main ones, but of course, there are other diseases that also lead up to requiring a lung transplant. Typically, our patients require oxygen at rest or just with exertion. You might have multiple hospitalizations over a rolling year, a decline in your pulmonary function status. Maybe your CO2 levels are rising and you're not able to exhale and you're air trapping. Or maybe it's all part of like a decrease in your quality of life. Just doing activities of daily living is a chore, and it's becoming very, very difficult, and your quality is really gone down. Now, there are also some potential contraindications for lung transplant as well. Some of them are similar. We have the active smoking or less than 6 months smoking or any other substance use. Age 75, we kind of let that creep up a little bit higher on the lung side. We do it on a case-by-case basis. And if you are over the age of 70, we do have to make sure that most everything else is in perfect working order to be able to offer you a lung transplant in the 70s. If you have severe diffuse coronary disease, this is, where you've had heart attacks, you may have had stents, but now they're blocked, or maybe you need a bypass surgery because your heart is not needs revascularization. Sorry. If you have a bone marrow dysfunction, if you have a lot of neurologic deficits, again, if you have some psychiatric illnesses that are not managed well, if there's incredible deconditioning, which can happen to many people that are being referred to us for lung transplant, because this happens kind of slowly over time, but as you do less and less and less because you can't breathe, we have to turn that process around and ask that you use more oxygen so that you can get up and move and start reconditioning yourself so that you have more strength and more tone. If you've had a previous chest surgery, that can make going back into the chest a little bit more difficult. So again, it depends on what type of surgery you've had, how long ago, if you've had any complications from that in the past. Achalasia, this is basically a word that it's, which means if your esophagus has stopped working. In other words, your esophagus is like any other organ. It has muscles in it, and your muscles should be contracting to allow for proper digestion of food to your stomach. And if you don't have full functioning esophageal motility, then you'll be predisposed to a lot of gastroesophageal reflux, which then would put you at risk for aspiration pneumonia. And of course, we would not want to put a new set of lungs in you, have you regurge them all the way up and throw stomach contents down into your new set of lungs, which would permanently damage them. So we are very, very careful to monitor and evaluate for esophageal dysmotility. Or there's some other end organ diseases. You must have normal liver function and kidney function. Again, the weight is a concern. We would like your BMI to be less than 30 and greater than 17. Prednisone use, a lot of our patients that require lung transplant have been on steroids for years. We would need to have that titrated or weaned down below 20 milligrams a day so that you would be able to be safely taken to transplant so that your wounds would heal. We would make sure that you didn't have psychosocial or financial concerns. If you don't have the adequate insurance, you're out of network, you wouldn't be able to afford your care. We would have to find the right center for you that could cover you. If the cancer is less than less than 5 years, you're an acceptable candidate. But if it's over, I'm saying that backwards, I apologize. Cancer in the last 5 years typically is a contraindication, with the exception of local skin cancers. However, with the new cancer treatments, we can now offer transplant in less than that amount of time. It depends on what type of cancer it is, but that's actually a significant positive for many of our lung transplant candidates. If you have any colonized or resistant infections, I specifically think of patients that have bronchiectasis or cystic fibrosis, and they have a history of something called cepacia or burkholderia. That particular organism is quite hard to eradicate, and we would not be able to offer transplant, because if we take the old lungs out and put the new ones in, you still have the upper airway into your sinuses that may be colonized with that same organism, which would then infect the new transplanted lungs. So we would have to make sure that you didn't have that particular resistant infection. Chronic mechanical ventilation. If somebody is in the hospital on a ventilator, we used to say this was, an absolute contraindication. It's now not so much so, because it could be the fact that you recently got so sick that we had to put you on the ventilator. But that is no longer a relative contraindication. ECMO is also, this is a extracorporeal support to give your lungs a rest. And that would be somebody that's hospitalized and pretty sick. So a lot of times, unless the patient can really tolerate the ECMO circuit, that's usually a contraindication for transplant. Our lung transplant evaluation, very similar, with tests and consultations by the social worker, the nutritionist, the thoracic surgeon, lots of teaching by the transplant nurse coordinator. You may have other consultations like an ENT or a hematologist or a gastroenterologist, depending on your particular other diseases. We do a lot of diagnostic tests the same way, the CTs, the echocardiograms, the cardiac caths. One thing, like I said earlier, we do a lot of swallowing studies to determine that you have good esophageal motility. We also do a test called a sniff test to make sure your diaphragms, which is the biggest muscle at the bottom of your lungs that supports exhaling and inhaling of oxygen, necessary. And we do a lot of PFTs and 6-minute walk testing to see your endurance with oxygen. We do all the same lab work and serologies and tissue typing. We expect the same health maintenance exams, colonoscopy screening, mammography, PAP testing, GYN exams, PSA testing, and dental clearance. All of that needs to be healthy and cancer screened as well. So if we put you through the evaluation, we deem that you're a candidate, we will then, of course, put you on the transplant list according to the UNOS, United Network of Organ Sharing requirements. You will be assigned a CAS score, which is considered a continuous allocation score. The score can be 0 to 50, based on your everything from your age to your height to the diagnosis to how much oxygen you're on to how far you can walk. The more conditioned a person is going into transplant, the higher their score. They feel that, the more conditioned a person is going into transplant, the more successful the outcome will be. And your CAS score, of course, can be updated very regularly, because as your clinical symptoms change, if you've gotten worse, your score should go up so that you would be at the top of the list and be getting the offers locally, regionally, and nationally. Your lungs are allocated according to your blood type and the size lungs that you need. Lung transplant surgery, you can either have a single or a double lung transplant. Depending on your lung diagnoses, some people can only have doubles, whereas others could be single or double. In this case, someone with a diagnosis of IPF, which is interstitial pulmonary fibrosis, or ILD, You can have a single, which could be a thoracotomy incision from the midline over to the side of your chest. This can be done with or without bypass, and that's totally up to the surgeon, depending on your cardiac status at the time of transplant. If you require a double lung transplant, this is considered a clamshell incision. And the best way to explain where that incision is, I would, if you ladies, if you think about an underwire bra and you go underneath your pectoral muscles, just like where the underwire would go, that's how they would cut you for a double lung transplant. You also can be either on or off bypass for that. And such the diagnoses that mandate a double lung transplant would be cystic fibrosis, sarcoidosis, and pulmonary hypertension. Our postoperative care, you can expect in the hospital, you have an ICU stay of about 4 days. During that time, they are taking the ventilator off of you. They are removing a lot of IVs and drains. They're getting you up into a chair. They're monitoring for signs and symptoms of infection or rejection from the get-go. They're making sure that you like your new lungs, your new lungs like you, all the medications that you're getting, your body likes those, that they're tolerating them, your kidney and liver are working well, your pain is under control. You're working with physical therapy at the bedside. You're getting a lot of pulmonary toileting. We actually will do bronchoscopies, which is where they take a flashlighted tube while you're asleep down your throat into your lungs. And we take a look at the anastomosis site where your lungs were connected to the trachea and bronchus tubes. And we take biopsies to make sure you're not having any rejection at the cellular level. You'll be using a spirometer at the bedside to show us how well your new lungs are working for you. They'll be monitoring you for side effects of immunosuppression, all those medicines that I told you about, to make sure that you're tolerating them well. We can tell that by blood glucose levels, your blood pressure, and your renal function. So when you go home from the hospital, you can expect that you'll come back to have weekly clinic visits. You'll have a lot of blood work done the day before so that we can titrate or wean the medicines that you're on. You'll get pulmonary function testing so we can see how well they're doing. We will make those medication adjustments as needed. And then you'll have ongoing surveillance. Okay, this is for chronic rejection, bronchiolitis obliterans syndrome, restrictive allograft syndrome, and malignancies. Again, you're immunosuppressed, so you're at a heightened risk of skin cancers. And sometimes there's another malignancy called PTLD, which is post-transplant lymphoproliferative disorder. And that's where your immune system, you have B cells and T cells. Well, the B cells grow out of control, and they sometimes can be linked to like the Epstein-Barr virus for up to the first year after transplant. And I just want to share with you some pictures here of some of our lung transplant recipients who have gone on and are living their lives with their new lungs. So there is life after transplant. And I guess I will stop there and open it up to any questions that anybody may have.
Thank you, Gina, for that great presentation. We do have some questions from the audience. So we're going to start with the first question from Kelly. Could you say more about being able to get a transplant in less than 5 years post-cancer because of new cures? Which cures and how many years?
Okay, so I can speak to a few that we've recently discussed. Somebody that has prostate cancer can now get their treatment, and after they've had their treatment, literally we could start the evaluation and listing process immediately. Someone with prior breast cancer, depending on the stage of their cancer, could be about a 2-year wait. Some cervical cancers, depending on the type and the extent of it, could be 1 year after having cervical cancer treatment. They're the more common ones that seem to have had the most success with cancer treatments that I can think of off the top of my head right now.
Thank you, Kelly. I think that answered that question. And there's another question from Kelly. And I might butcher some of these words, so I'll just give you that. It says here, her question is, you said that Tacro, Celsipt, and Prednisone, I'm not sure if that's how you say it, are 3 that must be taken for life. That doesn't match what I've experienced, where most of us were weaned off Prednisone by 1 year, and the Celsipt can be switched out for everolimus or one of the newer IMIS drugs. Do most people stay on all 3?
Okay, so most people stay on all 3. I do know that from a lung transplant perspective, we keep everybody on the prednisone. On the heart transplant side, they have weaned them down sometimes, but I don't think it's routine. As far as the everolimus version of tacrolimus, that too is a newer version of tacrolimus. And yes, some people are switched over to that. It's a once a day sustained release, which I think some people seem to tolerate better than the twice a day tacrolimus. So sometimes there's some individual reasons for maintaining all 3, and depending on whether it's a heart or a lung transplant that we're talking about.
Wonderful. Thank you, Kelly. And I'll give everyone maybe 1 more minute to type in any additional questions that you may have for Kelly. And again, please use the Q&A chat for that. And while we're waiting, I just wanted to quickly remind everyone again about your individual schedule, that all your sessions will have separate Zoom links and that you will be able to access links 15 minutes before the session starts. And the webinars will officially open 5 minutes before the start time.
While I'm waiting for any more additional questions, I did want to emphasize that maintaining strength and conditioning while you're waiting to be considered for a lung transplant is probably paramount. Up and moving on oxygen, I don't care how much oxygen you're using, but to be able to get up and move and keep yourself moving is going to be so important and necessary. And it helps with recovering after transplant. So it's not only one of our requirements, but it's also so much more beneficial for a more speedy recovery.
Kelly, there are no further questions.
Okay.
All right, so that will conclude this first session, and we'll see you at the next session. Thank you so much.
Thank you.